Hey guys, welcome everyone. Today we are going to discuss primary hyperparathyroidism. We'll be discussing regarding what are the clinical features and what are the common causes of primary hyperparathyroidism and how to treat primary hyperparathyroidism, what are the important differentials. So please stay till the end of the video. We are going to have lots of learning and capture all the high yield points. Okay, so hyperparathyroidism can be demarcated into primary type, secondary, which is generally because of low calcium of renal failure that stimulates the parathyroid gland to secrete PTH, or it could be an autonomous parathyroid gland, that is tertiary hyperparathyroidism that could be there. So the most commonly we see that primary hyperparathyroidism, the most common cause being adenoma. So this particular presentation we will stick to the primary hyperparathyroidism, and we will discuss secondary and tertiary hyperparathyroidism in some other video. So this we will discuss only primary hyperparathyroidism. So the common causes are adenoma, that is the important cause, that is a benign tumorous condition. Only hyperplasia without tumor, which could be diffuse or a kind of a nodular hyperplasia could be there, or even rarely we can get even parathyroid carcinoma as the cause. Familial syndromes can be a cause in some cases, like multiple endocrine neoplasia MEN1 and MEN2 syndrome, which is due to the mutation of MEN1 gene and RET gene respectively. And so these two are commonly associated with familial syndrome of hyperparathyroidism. Familial hypocalciuric hypercalcemia, mutation in the calcium sensor gene, that can also be defective. Albright hereditary osteodystrophy with PTH receptor mutation, that can also be a possible cause of primary hyperparathyroidism. So parathyroid adenomas are a most common cause of primary hyperparathyroidism. 0.5 to 5 gram, well circumscribed nodule is seen, and they are mostly composed of uniform polygonal cells with small centrally placed nuclei. Mitotic figures are generally rare, but sometimes pleomorphic nuclei and endocrine atypia can be there, but that is not considered to be malignant. So the invasion is most important rather than the endocrine atypia, which may be seen in some cases of parathyroid adenomas. So as you can see over here, a localized red-brown lesion is seen. So this is parathyroid adenoma. Parathyroid hyperplasias are due to the mutation of cyclin D1 and MEN1 gene. So there is a asymmetrical, so they are more commonly seen in MEN1 MEN syndrome, or sometimes they may be sporadic as well. So there is a frequent asymmetry, so that means both the sided glands may not be equally involved, and there is a cheap cell hyperplasia on microscopy, and even abundant water clear cells that is also being seen. So cheap cells show marked hyperplasia, that is the important feature. Parathyroid carcinomas, on the other hand, are much rarer compared to that of parathyroid adenoma, and they are quite deceptive grossly as well, and there may be circumscribed lesion. So it is maybe a quite circumscribed lesion, may not be able to demarcate completely from adenoma. Diagnosis is based on invasion. As you can see over here, tongues of invading tissue is there. So like infiltrating margin, a kind of an invasive margin into the surrounding normal tissue, that is the key feature in diagnosis. So that is the local invasion, and some cases even distant metastasis can also be seen. Symptoms of hyperparathyroidism that are commonly seen is bone pain, fractures, and there will be increased calcium level due to bone lysis, and that will cause nephrolithiasis. So nephrolithiasis, renal stone will be formed, which will be composed of hypercalcemia, that will cause renal stones. So renal calculi, renal stones will be formed. Constipation, ulcers, gallstone can be associated, and increased calcium level will cause depression and lethargy, weakness, fatigue, and calcification may be also noted in the valves and may leading to heart valve destruction. ECG findings of hypocalcemia will be shortened QT interval, shortened ST, and prolonged PR interval, and the Radionuclide scan may demonstrate a kind of a localized lesion in hyperparathyroidism that could be diagnostic. Other morphological features are bone resorption. There is a hemorrhage and cyst formation which is called as osteitis fibrosa cystica, and in some bones we also get a solid tumor where there is aggregate of osteoclast, reactive giant cells, hemorrhage. They together form a brownish lesion which is called as brown tumor of hyperparathyroidism, which could be seen in very commonly in the jaw bones and mandible and maxilla, and also tibia. These are some common site, but virtually it can affect any of the bones. And the non-skeletal, we have already discussed the nephrolithiasis, and calcium can also be deposited in the renal tubules as well, that is nephrocalcinosis. Metastatic calcification of various organs like stomach, lungs. So excess calcium can get deposited virtually anywhere. So this is an aggregate of you can see this aggregate of osteoclast, giant cells, and reparative tissue, connective tissue, and all are seen. Hemorrhagic debris may be also seen. So this is Brown's tumor, and here radiologically you can see the cystic lesion over here, osteitis fibrosa cystica, and it is also a kind of a Brown's tumor will also manifest as a kind of a lytic lesion. Both of them, they will radiologically they will be seen as a lytic lesion. And here also you can see the osteitis fibrosa cystica, cyst-like lesion. So here Brown's tumor and osteitis fibrosa cystica both will be seen as a radiolucent lesion. So let's have a quick recap. Primary hyperparathyroidism is most commonly caused by parathyroid adenoma. Familial cases are commonly seen in Men's syndrome, and bone pain, fractures, renal stone, and overt ECG changes are seen. Surgical removal of the tumor or enlarged gland is the treatment of choice to get rid of the persistent symptoms of hyperparathyroidism. Thank you for watching the video. Please subscribe to the channel, hit the bell icon, and follow in our different groups. And please stay tuned for the next video. See you in the next video. Thank you.